the record, I have official notice of the publication for the Daily Record. There is a copy of the Open Meetings Act over here on the north wall of the chambers. Anybody wants it? And with that, we'll go into roll call.
Here.
Here.
Online.
Alrighty. With that, we'll go to item 2, approval of the minutes. Is there a motion to approve the minutes from January?
Motion approved.
Motion by Festerson. Is there a second? Second by Espinosa. Roll call. Yes. Item 3 is approval of the items for approve. We have items A through B. If nothing needs to approve, accept the motion to approve items A through B. A through E, sorry. Motion by McNally. Is there a second? Second by Weiss. Roll call.
Yes.
Yes. Okay. We'll go to item 4 and the director's report. Dr. Hughes.
Good morning, everyone.
Good morning.
Welcome to February. To start with today, I have an employee recognition, and I'm going to go ahead and call Jared to come up, please. We have one of our environmental health specialists who is celebrating 25 years with the department as of the 8th, Mr. Jared Jensen. And we are just totally thrilled to have you with us and just are very grateful for all of the work that you do for us. I know personally, Jared's been so wonderful about helping to educate me on sanitation issues. That group is, you know, anytime I have a question or need to bounce something off of them, I know I can go down and sit with them. And Jared's always got great insight and perspective to give on things. And so congratulations on 25 years with the department and for being here today. And we'll give you a certificate.
Right. Thank you.
Thank you. Oh, we got to go get a picture. Would you like, do you have anything you'd like to say?
No.
No worries,
Appreciate
Jared?
it.
Okay. Appreciate it.
Okay, just a couple of other updates that I have for you today on just kind of some general things. First of all, our community health needs assessment or community health assessment, this is the first time that we have been able to launch the survey, the public survey for that, in a couple of different formats. So in years past, the survey has only gone out via telephone, and this year we're really, really excited that we're going to be able to launch this also on an online platform. So people will have a couple of different avenues through which they can take our survey. And I know it's supposed to be coming out very soon, and so I just wanted to put it out there so that you're aware of it, and hopefully if you're able to promote it, that would be fantastic. And also, if you can take it, we would also appreciate that. It is a bit of a lengthy survey. However, since we have it in that online format, hopefully that will allow people a little bit more flexibility in taking that. It is 117 questions long. That's down from what it was before, and we will continue to whittle that as we're able to over coming years. But this year, that's what we settled on, and there will be a QR code that goes up on the Wellbeing Partners website. It'll be on our website as well. that you'll be able to just scan to get you straight to that survey. And so we would certainly appreciate any help that board members can give us in getting the word out. Of course, the more people take that survey, the better information we have to work with when we're identifying trends or gaps or things in our community that we need to work on. So we appreciate that help in advance. And I believe that will be open through May, if I'm not mistaken. Just a couple of things on the health department specifically, and I may have my deputy come up here because he has really jumped into his role and has a good grasp on all of the little things that are going on. But I did want to let you know just a fast update on security in our building. So as you know, that's been kind of a big push for us this year with our other organizations that share our building, is to really improve our security in our building. And we were finally able to get our panic buttons installed. So we're very excited about that. It was a lot harder than you would think it might be to get all of those installed and working properly. And we certainly have had, things happen within the building where someone needs assistance to their office or to a certain area in the building, and we haven't really had a good way to make that happen. And so we now have those installed, and I know that that's going to go a long way toward helping people feel safe at work. So we're excited about that. Another thing that we were able to establish this past month is our MARTI contract. And what this is it's a contract with a company that provides language services. So we do have people within the health department who are bilingual and are able to assist us, but there are many, many more languages spoken in Omaha than we have the capacity to provide interpretation or translation for within the department. And so that means we have to look at outside solutions for that. And so MARTI actually has kind of a video platform that gives you kind of the benefit of both in person and virtual. So we're able to get interpretation services when we need them in whichever language we need, but there's also a person that's on video that's able to provide that. So we get kind of the benefit of both ways of doing it. A lot of times before, you'd have to pick up a phone and you're trying to do interpretation over the telephone, which can be pretty challenging at times. And so this is going to give us an additional solution to make sure that we can serve anybody that we need to, really. And that's not just within, our building, but also it could be out in the field where that service is used. So we're pretty excited about that. That's also been something we've been working on for a long time and are very excited to have established. And then I just wanted to really quickly give you an update on our work towards strategic planning. So I told you that a little bit later in the year we'll start doing actual strategic planning. We have a little bit of foundational work to take care of first, and we were able to knock out the first portion of that this past week. The management team was able to meet with a facilitator and really go over and develop what are our core values as an organization. We have core values that had been set previously, but we really wanted to look at those and make sure that they were still representative of who we are and the work that we want to do. And so we started that work, and we still have a couple more steps in there where we want to engage all of our staff who are interested in doing this kind of work and bring them in and make sure that we have feedback from across the department on that. And once that's finished in the spring, then we'll move into strategic planning, and we're really excited just to be moving forward with all of that work. So I will have more for you in coming months about what's coming out of this work, and I'm really excited to get to share that. But until then, Justin, do you have anything that you wanted to add in terms of updates this morning for the building?
Good morning. Like Dr. Hughes said, we did install about 45 panic buttons throughout the building, so we're really happy that that's happened. All the clinic areas, GA, in addition to the health department, juvenile assessment, etc. We continue to update and replace some of the furniture in the building. It's quite old, so we're working on that. We're also working on continuing to update technology throughout the building. We're moving all of our staff from desktop computers to laptops. It's actually going to be a cost savings for us because in the past we were buying 2 machines per person. So now we just buy the laptop with a docking station. And so that also makes us more mobile should we have to mobilize and leave the building for whatever reason, for example, like the TV response. We started closing restaurants yesterday for restaurants that have not renewed their permit. So just so you have that on your radar, I think there are about 60 as of yesterday. It was a busy day. Jerry McKay's office, the finance office, was doing a fantastic job of making sure they were collecting those when folks came in to pay. And the only other thing that I'll mention is that next month we'll start gearing up for our budget season. And so that'll be a lot of work as we prepare for the fiscal year 2025. But that's all I have. Thank you.
So Justin, hold up before you go. It's about, I couldn't count, but let's say it looks like it's probably about 34, 35 or so, maybe, that were on the list. How many has it, since yesterday when people came in, how many you think it's been reduced to?
Roughly 18 maybe.
Left? Okay.
No, 18 that we. that
Came
were-
in
I think
yesterday?
like 9 that we actually physically closed. And
Okay.
then there was roughly maybe another 8 or so that came in and actually paid due to the fact they were hearing in the public or in the press that we were
Okay.
closed.
Okay. All right.
I just want to follow up on that too. So I think that's probably is the case. And I think there were some on the list I noticed that are going out of business. I'm sure that'll take the list down a little bit too. But are they given a grace period then to come in even after yesterday to
No.
fix that situation? Or how does that
No,
work?
they've received several notices so far. Originally, Jerry, was it back in October?
Well, so
Or why don't you come up
Yeah, you need,
and just give a timeline maybe of,
So our general process is at the end of October, we do the billing, we mail them out November 1st. They have 60 days to pay. And then the 10th of January is when we assess the late fee. And at that point, we give them roughly about 2-week time period to come in and pay that. Then we have staff call and let them know that they are delinquent. And then at that point, then we give it a little bit of time, and then the first part of February, around the 15th, we make sure that the list is accurate and we start closing.
Okay. And if they wanted to reopen, how's that work? Is there a time
So
frame?
reopening is if they're they go out and they close them, they get a reinstatement fee assessed, and then when they pay that with their past due and their actual bill, then we will set up a time to come out and do a inspection and reopen.
That's a time frame of a matter of months or?
No, usually the ones that were closed yesterday, if they get in and pay, we can usually within a day, not the same day, but within the next day, we can usually get out there and get them back open.
Okay. And if someone has closed, they just need to notify you and they aren't, are they fined or do they owe you some
Well,
kind
no,
of-
if they've closed, they haven't operated in this fiscal year, then we just waive or void the invoice.
but if they do plan on closing within the next year, they still have to come in and renew because they're operating this year, if that makes sense,
Yes.
right?
Okay.
So even if they're gonna be open for 6 months, they still need a permit to be serving food.
Okay, thank you.
so I want to, so that little point you made, I just want to make sure. So if you're open, you just need to pay your renew. But if for some reason you don't pay your fee and you're closed, you need to pay your fee and you all come back out and reinspect.
That's
So,
correct.
okay,
And they're assessed a late fee.
okay. All right. Anybody else? Thank you. Any questions for Dr. Hughes? You got any legislative update you want to share or what friends may be doing?
Right one, is this the right one?
Yep, there you go.
Okay. I do not have a legislative update today. I know that there's a whole bunch that's going on.
Okay.
It's just all kind of in transit right now.
Okay. Alrighty, we'll go from there to presentations, and we'll go to item A, and that's the Nebraska Medicines Community Benefit Report.
Actually, it was, oh, I'm so sorry. Did you have a PowerPoint?
I believe we can. I'm still learning here. Yeah, email it to me. Let's see here. Okay. It's Heather. Dot. B as in boy. LAZICE. Yep. C as in cat. Yep. V as in Victor. I'm sorry. At. Let's see. Replace. At Douglas County. -NE.gov. Oh, no, yep, hyphen, NE.gov. Okay. Okay. Waiting here, so. Ah, there it is. Okay. Let me expand and download. Okay, and let me close this one out. Okay, and share screen. Okay, you're welcome.
Good morning. Thanks for the patience as we get set up there, and thanks for the help, Heather. I'm Becky Jackson, Director of Community and Patient Engagement at Nebraska Medicine. I do want to open and acknowledge that Dr. Andrea Jones is my medical director and partner in that work, so thank you for this. I could not do this on my own. It's collaborative and team effort across the board, so I want to open with that. Before I really get into some community health updates and then our community benefit updates, I do just want to give kind of an orientation to when we talk about Nebraska Medicine, who do we mean? We have many names and many things that we are sometimes called. So when we refer to that and what does Nebraska Medicine encompass, it's all the clinical operations at our campus. So that's Nebraska Medical Center, Bellevue Medical Center, and then the Nebraska Medicine Clinics. So our largest campus down the street from here at 42nd and Farnham, and Bellevue Medical Center in Bellevue, as well as over 70 specialty and primary care clinics across the community. We move into really what we prioritize, and I believe we are the last of the health systems to present, but we're also the last of the health systems in cadence of order and when we've approved. So we approved our community health implementation plan in late 22, so we're just a little bit over a year into the work of this process. So using the same data survey, and we're very engaged and interested in what's going to happen in the 2024 version and seeing that and promoting that within our patients as well to get a lot of engagement with that. Really, we looked at those needs and we prioritized for our system based on a multitude of methodologies. And so we wanted to see what were the priorities that we saw larger areas of disparity among Douglas County in particular. We saw a lot of differences in Northeast and Southeast Omaha, so prioritizing some of those needs that are listed here. Stronger focus on those that we heard from the community. This wasn't necessarily about what are our clinical priorities as a system, but what are the communities saying and what do we need to hear and address from the community? That's really our purpose and strategy in this. And then supported by other external data and aligns with our other goals as it relates to health equity, DEI efforts. And then I think the opportunity that, we put these implementation plans together. It's a 3-year process. That seems like some time, and then it is really not a lot of time when we speak about a large academic medical center. So where can we start to see some impact and change in a shorter period of time? So again, approved in late 22, we created an action team for each of these priority areas. So they've been working diligently since really early 2023. And then, so I'll share some updates from each of those areas, but then also wanted to speak to some of our overarching strategy is really to highlight how we are increasing access to care, and addressing social drivers of health. And so 3 specific programs that we've been working on in the past year that will address those areas a little bit more specifically, and obviously have impact on each of these priority health needs. But I'm going to share on some of the slides here just a little bit about, let's try and get it here. So the goals are going to be in front of you, and I'm going to speak to some more of the programmatic work that's been happening. So these are our overarching goals. We have implementation activities that the team's created among these. This is some of the more broad, high-level goals, but really thinking about within the community, how can we increase awareness about those options for diabetes treatment? Weight management goes along with that, and healthier food options. So what things that we're focusing on are expanding access to the diabetes prevention program within the community. So we have programs on campus that are open to patients and addressing ways to expand that more available in the community. Lots of activity in October around Diabetes Month, Diabetes World Day, both internally and externally for us to promote just healthier habits, even some more equitable language around patients with diabetes, right? And how we address that and make them feel supported in that space. Increased access to clinical nutrition and diabetes educators within our clinic structure that are also able to support community efforts has been helpful in that regard, and continuing to expand that program. From a clinical technical standpoint, something that has started here in the past year is that we've incorporated iArt, which is an AI system which is really looking at diabetic retinopathy testing. It's an FDA-approved system that is currently in both of our family medicine clinics on both of our campuses to really provide for quicker treatment, quicker assessment of patients and those complications that may arise when they have a diagnosis of diabetes. Expansion is planned for that program as well. And then internally, we have over 9,500 colleagues within our system. So we know we're a large employer and make up a lot of the community. So how do we address that for our colleagues as well? So making sure that there are programs available, and there are programs that are covered within our benefits package for patients and colleagues with type 2 diabetes or pre-diabetes to help support them in their health and weight loss management. In terms of a few mental health updates, obviously a big cadence for the community. There's a lot of partnership here and a lot of prioritization in this space for all of the health systems. And so partnership within the Regional Health Council and some increased opportunity there for us to pull into that. One of the things that we're really excited about is in continuing to expand our behavioral health connection program. So that is a system open to any and all community members, regardless of patient affiliation, obviously, but connecting adults with any type of psychological or substance use disorder to area resources. So addressing what are those other factors that they may need support in and helping them get access to that. I think as I shared last year, we had just opened our psychiatric emergency services unit, continue to see a lot of utilization in that space, continuing to think about ways we can expand and develop those partnerships both in Douglas and Sarpy County to continue to create access for that care outside of that more emergent situation. Universal suicide screenings and safety plans are in place for all of our hospital admissions and primary care visits if there's a behavioral health component to that, and making sure that we're connecting our patients in additional ways. We know that our primary goal is increase the access and the number of practitioners because we know the need is so great in our community and the challenge is getting the practitioners to support. So we're having to think a little bit differently. I think hiring in this space has been difficult, not just for us, but for many other systems. We hear about therapy shortages and things across the nonprofit space as well. So we're trying to think about how we can do that differently. So that's incorporating things like psychiatric consultant services within our primary care model, for example. So are there other ways to embed that into what we call our primary care medical home so that patients have better access and the providers feel equipped to provide additional service within their scope? Moving into nutrition, physical activity, and weight, we're going to talk a little bit more about some of our key projects around this one in a moment too, because they really are addressing some of the food security components. But we really are promoting and advocating for food is and food as medicine. So when we think through that, some of our partnerships will speak to that a little bit more. but really thinking about those nutrition-based resources that we can provide to patients in the community. So everything from, we know that everyone does not learn in the same way from an educational standpoint. So providing tactile plates and placemats that can be used to talk about portion control and healthy choices and foods that work for that. Partnerships with community gardens in this space. We're getting ready to have some of those conversations here as we get into garden season. It's felt a little bit more like spring this past week, so it's getting closer. And then some physical activity components, looking to start what's called Walk with a Doctor program. And so thinking about that through our spaces and our clinic spaces will be coming up soon. So bringing the community together to engage in a physical activity with our providers at that time. We also, one of the big things this team has been working on is March is National Nutrition Month, so put that plug out there for you as well. But we're hosting a large campus-wide food drive, and so we have everything from nutrition students and groups that are really engaged in this process for us to be able to support our community-based organizations that are supporting food security across the region. And we'll talk about, again, a couple of other big projects related to nutrition in just a moment. In terms of our last priority need that we've highlighted, prenatal health and infant mortality, we've seen a lot of collaboration in this space. One of our strong partners is Ivy Black Girl, and we're really grateful for the partnership that we're able to engage with them in the community. And so that has looked like things including sponsorship of the conference. We think about Nebraska Black Maternal Health Month and being active in those activities there, as well as supporting the doula training efforts that are going on with that organization. In particular, now hosting the site for doula training in that next class that is just getting started and underway. This also includes things such as partnering with statewide organizations. There's through the Nebraska Perinatal Quality Improvement Collaborative, there's now a birth equity initiative that has just started and engaged with that project, really, which includes looking at our data first and foremost, where are there opportunities within our own system, but then enhancing the patient feedback that we collect from this the group of within this spectrum of care, instating a doula policy within our system, and then increasing and enhancing postpartum education. So really some of the goals around that fall into line with what our goals from a prenatal health team include. This group is also involved in advocacy for the Medicaid expansion to the 12 months of postpartum coverage, something that we've been very passionate about, looking at also the maternal equity, but then also things such as supportive community breastfeeding classes, community baby showers within that spectrum to make sure our community has access to those needs that they have. And we know that during that time there are a lot of needs in that pregnancy and postpartum space. Another great partnership to highlight here is an engagement with the Nebraska Diaper Bank. I believe we're the first, probably not going to be the only, but the first hospital that is in partnership with them where we're actually able to give diapers to the patients at delivery through the Nebraska Diaper Bank. So patients that qualify for that are leaving the system with care. But then also the most important is what is that bridge? So once they've left our system and returned home, how do they get access and getting them connected and affiliated with that program? And some staggering statistics around the need around diapers. And as we see social drivers of health change, people are having to prioritize. And so if we can support the health of the infants that way, really excited to be able to do that. So another strong partnership we're excited about that started here in the past year. A couple of other things that really impact all of those areas, and so call them out a little bit more specifically, is that we have, as many of the other health systems are probably sharing, started with our social drivers of health screening within the system. And so there are some CMS requirements. This aligns with some quality reporting, so I want to acknowledge that. But it's also part of the CMS and Joint Commission health equity work that they are really striving for all systems to be engaged in. So that really includes screening patients around 5 domains: for food security, housing, interpersonal safety, transportation, and utilities. Acknowledge and recognize that there are more, but that is what our starting point is for now. We just went live with this just a few months ago, so in November of 23. This is currently screening for all inpatient adult admissions. And so in a short amount of time, we're excited that even over that time period, we've seen over 58% of our patients. Again, we're tracking by discharge, so discharge patients within that time had at least one question from each of those domains addressed. There's at least 2 questions per domain on our system and recommendations. So at least one of those questions per domain was addressed during that time. So opportunity to grow. This is early data. We'll continue to monitor and adjust, but then what we're really excited about is to have that fueled information to drive our future collaboration and partnerships. What are the needs that we're seeing within our patient population, and how can we enhance that? So I anticipate having more to share about that in future presentations. The other exciting piece of this is that we do have within our primary care structure a community health worker role. So if there are patients that are coming through that system and have not had a screening, it's being addressed in a primary care setting. So that those are being captured elsewhere, trying to kind of pull that data and those reports on that piece too, so that patients are not getting left. And we know that we have a really strong referral process within our social work and our then community health worker team to get that get a patient's addressed to those resources. Speaking of that, again, as I address kind of our food as medicine component and thinking through that, we are also really grateful for our partnership with No More Empty Pots, and we are piloting a new program with them to help us assist patients with accessing food directly. So the way that looks currently, and this started about 2 weeks ago, so I want to acknowledge we're really excited about it, but it's very new. This is a referral that comes in through our primary care system. So we've got about 6 clinics that are in our phase 1, and those are the ones that are primarily in our Eastern Omaha side of our distribution of clinics. And so it starts within the primary care model. So anyone within that space can be a provider, could be a dietitian, could be anyone in that space can make a referral. It goes through our social work or community health worker team, and they make the referral directly to No More Empty Pots. Those patients are then eligible for either a community-supported agriculture or CSA box of fresh fruit and vegetables or prepared meals. And then as No More Empty Pots opens their market space at Highlander, if you haven't seen that, I encourage you, put that plug in for that team. They will be offered gift cards to use at their market, so they could go and purchase the items directly. So best case scenario, we think about this as client choice and having individual choice in the items that you're interested in that are healthy, they're going to support you and your family. And so we're excited for that piece to open. But again, this started about 2 weeks ago. We've already seen over 13 referrals from our team that have gone through. So this is a great need within our patient population in the community. We're excited to see how we can continue to expand this and continue to engage with increasing resources to support that. The other piece I just want to call out is that we also then have the capability to refer them to a dietitian if needed for any follow-up. So if there's additional components, there are follow-up pieces of this. It's not just a kind of a one-off. We continue to work with that patient and their family as needed. And the great piece about this is that the options that are available are really can adhere to any type of dietary restriction. So really, really healthy and support any type of diet that is required. So another fantastic project we look forward to updating a little bit more on that we have started. And just also wanted to put a little bit of a plug in. If you have not had a chance to see our new Community Wellness Collaborative space that opened in September, really encourage you and reach out. I'm happy to arrange a tour for you if you haven't had a chance to see it. But the Community Wellness Collaborative is a joint UNMC and Nebraska Medicine space that's dedicated to supporting the needs of our community. This is not a clinical space. I just want to really reiterate that. Located at 2120 North 29th Street, it hosts classroom and gathering spaces for a multitude of community-wide events. All 4 of our priority health areas are connected to this space in terms of programming and to support community wellness. So for example, I mentioned behavioral health connection earlier, and that's specifically patients needing resource support. They're on site at this location once a week if individuals need help. We have a community health worker that's housed in this space as well. And then again, some other things like I've mentioned, doula training and other programs that are being provided there. But really another piece from our community building activities is something that'll segue into my community benefit component, is that this space is going to house things such as workforce development as well. And so Nebraska Medicine was recently awarded $250,000 through the American Rescue Plan Act to establish the Healthcare Collaborative Academy. This is a recruitment and professional development program to really look at difficult to fill medical support positions. And so post-pandemic, what can we do on educating, credentialing, and recruiting local residents that have been disproportionately affected? So grant funds will provide free education for certified nursing assistants, medical assistants, surgical technologists, and radiology technologists. And recruitment very specifically for this opportunity was targeted around where the CWC, as we affectionately call it, is located. So residents of the 68111 zip code and those in the Highlander community were targeted for this opportunity. And really excited, our first cohort of CNAs began their studies on February 7th. So a lot of new work that's happening really in the past few months, so as we're pretty early on to that. We'll certainly entertain questions towards the end. I want to segue a little bit into our community benefit capture here. We have shared and continue to provide these numbers. There's a link to our website as well, and we'll get that out to you afterwards. Working on our fiscal 23 report, which will be published by the end of June, but the most recent that we have is 2022, which continued to see an increase year over year. And so put this in front of you, and then I'll do a breakdown on the next slide and provide access to that if there are questions as well. But really, two categories that made the increase between 2021 and 2022 so significant. So we'll see if I might see if I can make that just a little bit bigger. We're close. We're really close to being on one slide there. So that breaks it down in terms of the numbers and how we break out that pie, we call it, of the community benefit. And so I mentioned that there's two categories that were significantly up from the previous fiscal year, and that's unreimbursed Medicaid, which was up $20 million, and our cash and in-kind contributions was also up $25 million. So if you're curious what's the difference from fiscal 21, those really were the categories that made the largest difference in that. And so we had some questions last year around kind of the cash and in-kind contributions. We make cash contributions to and grants to entities and community groups that share the same goals and mission as our organization. But one of those organizations, is UNMC Physicians. So we have that partnership in our academic medical partnership there. And so they're a nonprofit corporation with the same goals as our organization. And so that does capture really in terms of their work and covering from some of that is a large portion of the cash and in-kind contributions. And we had some questions about that last year, and I'm happy to take any more that I can speak to. But really thinking through the categories, that is the broader community health, where we see some of that largest impact, and then we've continued to see the thoughts of the impact from unreimbursed Medicaid as well, in that increase on our system. Ultimately, all of the conversation leading up to this point really impacts our community benefit work. So they really go hand in hand, thinking through our community health strategy and how we can continue to greater support the community. Several of the things that I've spoken to today will really be featured in our fiscal 23 report. And we are looking to maybe step a little bit less from the pie chart model and share some more stories and really impact in the community in our upcoming report. So we'll see a change in fiscal 23. So lots of teasers for next year, lots of things that'll be coming. I'm happy to answer any questions.
Let
Want me to go back?
me say, I thought it was a good report. But my question is from the last point you made. Explain to me the increased contributions to UNMC Physicians.
Right, so
I'm just curious, what is that, what does the increased contribution get to in meeting the points from the community health needs assessment? I'm just curious.
So that's a great question, and I don't know, some of the components that UNMC Physicians is providing is clinical practice activities across the community within our system and out, and they're also the vehicle for faculty members, so the training of students. I don't know that I would say that line of our community benefit report directly is a result of our community health assessment and our priorities. So I do think what we capture within our priorities impacts the other areas of our community benefit report. So specifically some of the other in-kind cash contributions outside of UNMC Physicians. I just wanted to emphasize, I think we had some questions last time that UNMC Physicians is probably the largest piece of that bucket, and I can go back to this. I apologize for closing
Is Physicians the primary care outlets?
So they would be, yes, they would be really in that clinic space.
Okay.
Correct. So they are also a nonprofit, and so when they have a shortfall, Nebraska Medicine, from a benefit perspective, is helping to cover that cost.
Okay.
Yeah, it's really not helping to clear the lines between Nebraska Medicine and UNMC at all, which is always the piece. But that
No,
we
I
are
understand the
directly
lines.
affected.
I'm just trying to,
Yeah.
seems like a creative way to
I
fill a
can,
revenue shortfall.
well, I can bring the breakdown too, and I can share that after. I think we shared some follow-up details last year as well. I think it's just engaging that that's the academic side of our partnership, and that's how it factors in from a finance perspective. So when
Mhm.
it does look like our numbers are significant, it is in relation to that.
Okay. Now, my other question, I'm just curious. So usually I see the food piece kind of together with the diabetes piece. So I'm just curious on you all's method of separating them. And it's not a right or wrong. I'm just curious in you all's philosophy, because usually I see that the food piece kind of up under the diabetes piece.
Yeah, we really felt that they were both strong enough to be priorities for our system. We felt that nutrition really impacts, to your point, all of them. And we have to have healthy nutrition across all of the priority areas, including the ones that we didn't prioritize. In terms of diabetes, we're really trying to make sure that it's more active assessment within the community of individuals. You need to know their levels. You need to know if they qualify within a pre-diabetic to then try and correct if they can. So we wanted to be purposeful in calling them out separately, acknowledging that those teams do have a lot of interaction and collaboration, because
Mhm.
it is close.
Mm-hmm. I'm just curious, what's your conversation with the growing discussion about diabetes, weight loss drug? What's your internal discussion about that?
You know, I think it varies. There are some providers that, you know, patients in the community can find it very helpful. I do think it has to be managed appropriately is the recommendation, right? That should not be something that's not addressed with a healthcare provider in that setting. And I know there's access through a lot of channels to obtain those. You know, I think our recommendation would be to try and find that in balance with a healthcare provider, and then knowing if you qualify appropriately and meeting the right components and getting the right follow-up care, right? Because those can, if not managed appropriately, could be a little bit more dangerous, but can be very helpful for patients and has worked for very many. So
Yeah, yeah.
you're seeing it more on a regular
Yeah, I
basis.
can just add
Yeah.
to that a little bit. We actually kind of discussed this as kind of future work to look at some of the disparities and equities in not only, I mean, they are being prescribed, however, our patients cannot get them, right? And so access is a huge issue, whether you're getting insurance coverage. Even when some patients are able to get coverage from insurance, it's still up to $500, $600 a month. And we know these drugs work. We know, just like any other chronic medical condition, obesity is considered that. And so oftentimes people need to be maintained on these medications. It's not like you can just start it and then you suddenly lose the weight and you can go off of them. That doesn't work for everybody. So I think that's an area that we definitely will explore more. We do not recommend, of course, the compound options that has been in the media a lot recently that are more accessible to people with means.
No, that I couldn't phrase it right, but yeah, you all got there. That's why I was interested in that disparity number. And
Yeah.
Okay. That's all I got. That's somebody else got. Oh, go ahead.
Thanks for the report. In many of these reports, I think we tend to, from the various systems, the majority of community benefit tends to be uncompensated care. I think that depends upon the population you're serving, and generally the uncompensated portion of Medicaid is a big portion of that pie. But in this case, that's not the largest category. I think it says 62% is the broader community health category there in blue, which is a little bit difficult to see from here. But I think 218 million of that would be the cash and in-kind contributions. Can you speak to that a little bit more about what that is or what that breakout
Yeah, so
consists of?
that is directly where it was talking about the UNMC physicians component falls into that category specifically. So, you know, part of this is a little interesting. We think about the community benefit and that intersects with community health, and then the finance and tax piece of this actual report, right? And so I've pulled together like our full, this is kind of our finance tax component, which is going to cover anything that is really falling at a shortfall and gets reported out on our 990 and our Schedule H. So to that point, it is the relationship with UNMC physicians that is a large portion of that cash and in-kind contributions piece.
Okay. And what does that consist of? I'm not familiar with what they do or
So they are the ones really providing the clinical practice activities. They're also a nonprofit corporation, have the same goals as our system. We're more on the operational side. So they are clinical practice activities within the community, and then the vehicle for faculty members through the College of Medicine and the University of Nebraska to really develop and integrate the clinical practice.
So that might be the in-kind portion of what you're talking about here in terms of the relationship with the community or doctor
Correct.
training or.
Correct. So some of that is anything that's happening within that system really falls into that. Separately, a little bit of the health professions education, which is a couple down, but also a significant portion of that at $52 million.
Okay. And then just a comment too about uncompensated care. There is a bill in the legislature, LB 1087, that's moving forward. I'm sure you're aware of it, and that the system supports. That could have a very beneficial impact on Medicaid reimbursements in the state, and potentially impact how this pie looks too in terms of uncompensated care. The hospital systems engaging in a program of work that would draw down another $1 billion in federal funding for Medicaid reimbursements and really be a sustainable contribution to our healthcare systems throughout Nebraska. So that could impact all the numbers we see in these reports
Right.
in a favorable way to healthcare systems and to patients, I think.
And I think it's also then making sure that our community has access to that resource and is getting signed up for those that qualify. And it's part of the work that we're trying to focus on too.
Yeah. Thank you.
Thank you for your presentation. Really great information. I have a couple questions in regards to your workforce development programs. You mentioned that they're targeted and very specific to an area in our city. Can you give me examples of how other communities can have access to those trainings? You mentioned CNA, MA, ST, and radiology technician.
It's a great question. And so this cohort is specifically grant funded, as I mentioned. And so I think it's really our learning environment for where our expansion can come from this point forward. So this class just started this month. At this point, really trying to recruit within that area and then grow from there. So I don't know the time frame of when we'll continue to expand that. It's going to be a little bit of fund dependent at that point. But we're really interested in continuing to learn from this cohort what is working and then expand as well with other partnerships. In particular, we know that that's a very specific area, but it's really our learning environment, kind of our pilot, if you will, to learn from how we can expand.
Is there specific ages of groups that you're looking into, and do you have any community partners specifically that you're working with?
So partners within the Highlander space right now in terms of recruitment, because we're thinking through, again, this particular cohort focused in that area, really looking at starting to recruit in late high school, and then anyone that's past it. There's really, to my knowledge, not a any type of exclusions on who would fall. When I have looked at the group that's in our first cohort, they are younger, but really wanting that to be open to anyone that's interested in that group.
Thank you.
Definitely opportunities to continue partnership.
We're just going to highlight the medical assistant program. So Nebraska Medicine also has the MA program that's still going on in the partnership with Iowa Western Community College as well as Metro. So they will get coursework and books covered. And I can share the website with you too, if that's helpful. But that would be open to any community member, not a specific for the 68111 region.
Thank you.
I got one last piece. Go back to your mental health slide if you can. And it's not related, but I'm just curious if you can disclose any of your discussion, particularly because this is what came to mind. The recent bill that was introduced about DEI, and particularly in the higher education pieces. I'm just curious what you all's discussion may be in regards to where's your alternative route if something like that was to pass, because it may not get through this point, but somebody's going to try it again. I'm just curious what the discussions are in systems about how do you recruit, how do you get through the block if that is. I mean, some other states have done it, and I'm sure that conversation was there, but not as a threat. I'm just curious what you all are pondering.
We are passionate about making sure that our workforce, our provider workforce, is going to be representative of the community. That's a goal for us across all areas. And to that point, finding providers in a behavioral health capacity that a patient feels comfortable with is extremely important. And so we have had some early conversations. I don't know that we have a solution for what that's going to look like. I do think it could potentially be a challenge, but we know that, we're trying to be a little bit more creative, if you will, of building into when you have a trust relationship with a provider in a primary care space, can there be more of a consult service there so that, if we aren't able to find that provider that is really reflected more of that group, then we can try that. I don't know that we've landed on a solution for that yet. I think we're still trying to monitor and see what happens and work forward. It's another struggle, I think, in trying to build this workforce.
Okay. All right.
Oh,
I
Chris,
like.
Sorry.
Sorry. Go ahead. Sorry.
Thank you. Thank you for your presentation today. Can you speak to, and it may be a different presentation, but can you speak to some of the health equity efforts that you are working on within the organization to help address some health disparities?
Yeah, absolutely. So we really have created a robust team around that, specifically within the past, probably going on 2 years. I think my time frame, I think everything post-pandemic, it's hard, is that 5 years? But we have a team now. So everything up from a chief that is focusing on diversity, equity, and inclusion for our system, that is really created into a variety of roles. So individuals that are focused on outreach and belonging, individuals that are focused on the training aspect of that. So that's everything from increasing our trauma-informed care platforms to be addressed, and then really through any type of system. So we've also formed what we are calling our HEDI Council, or Health Equity, Diversity, and Inclusion Council, which has a multitude of colleagues represented from across the entire spectrum of clinical care, DEI, community health representation as well. And all of those colleagues come together. We did an assessment with an outside consultant to look at kind of our landscape as a system, and then partnering within the community. And from that, I've created a wide variety of goals related to DEI efforts. One of the things I think I would also highlight, we've really had a robust employee resource group program that has developed. I think we're over 10 employee resource groups that are really any type of affinity, multitude of different areas in that. Our newest one that is going to be starting up here actually in a couple months is related to mental health and behavioral health for our colleagues. And so really driving that. I think the Community Wellness Collaborative is also focused on a lot of DEI efforts within the community and addressing that within our system, the workforce components, but a lot of great work that's happened in a short period of time with that leadership.
Okay. Thank you.
Thank you.
I like the direction that the reports went from the last time you all came, so I appreciate it.
Thank you.
Look forward to seeing the next one.
More
Alrighty.
updates.
With that, we will go. We're going to flip B and C and have Leah go first with item C.
I think so. Okay. Am I sharing? Yes. Yeah, that's what that means, right? All right, good morning.
Good morning.
Let's see, let me get this to the right view. All right, so it's been, I want to say 11 months since I last came up and did one of these. It was last March. So a lot has happened during that time span. Had a kid. And our programs have done a lot. I apologize. I do have a cold, so I might have to take a minute to compose myself. But so in the Community Health, Nutrition, and Clinic Services Division, we have our STI immunization clinic, which has STI services, adult childhood immunizations, COVID vaccines. We have STI prevention and control, which does our surveillance and outreach, education, and testing. We also have our WIC program with nutrition, breastfeeding, and healthy foods and formula. And then our health promotion group, which has tobacco, femur, baby blossoms, community health workers, and our
Leah,
overdose.
can I ask before you started? Can you minimize that corner there so everybody can see your full?
Oh, yeah. How's
Okay.
that?
Good. Thanks.
Yeah. And then our overdose prevention program. So we'll start with our immunization clinics. So some of the performance indicators, we have influenza vaccines, which was down a little bit. COVID has been down significantly, but that's also due to a change in our funding support. With the Bridge program, we now only provide COVID vaccine to those under and uninsured, which has kind of changed the process of how we've gone about and done outreach for COVID vaccines. The one good thing that I've seen out of our immunization clinic is just routine immunizations has increased since the last time I was up here. And then Mpox, we provided 183 in the last year. And then accomplishments and challenges. So as I mentioned, the change in COVID funding has really changed how we've done things for our immunization outreach. For our STI clinic, I will warn that we have been going through a new EHR, which is super exciting. We started implementing that in November, and we're still finalizing reports, so some of my numbers aren't all the way there yet just because we need to kind of pull those together. We were on 2 different systems in 2022. But for total STI clinic visits, we had 3,805, which is an increase from the last year. And throughout our STI clinic and outreach program, we had roughly a 14% positive out of all the folks that we tested. And as I mentioned, really the EHR has been our biggest win, as well as working through the pitfalls. I'm sure some of you that have worked in medical systems know how that can be. One of the other big challenges that we've had is some funding cuts. So really balancing how we can keep our staff on board, provide services in those expanded hours. We have had a tough time trying to balance that out because if folks call in sick, we're having to cut things short. So that's really been our biggest issue, and we're working towards trying to find out how we can create stable funding. And hopefully here in the next year or so with our electronic system, we'll be able to start moving into the billing phase. We're not quite sure. We're just starting to look into that. So we also, starting March 15th, will be increasing the price of our clinic visits. For as long as I have known, it's been $15 for a full visit into our STI clinic. We're now increasing it to $25. So I don't think it's ever been raised since I've known folks that have worked here. So STI prevention and control. So our surveillance and outreach, we've had our at-home testing program with about 519 requests. We've mailed out 206 kits and got 142 of those in return. The folks that were not mailed their at-home test kits were also just referred to our clinic because they probably had symptoms or something along those lines. It's better just to come and be seen and treated at our clinic versus waiting for a test kit. We have initiated our incident management team. So it started while I was out on maternity leave, and we're initiating that back up again to address the increase in syphilis cases throughout Douglas County. I will be excited to hopefully report back. We're meeting again this week and hopefully get you guys some additional feedback in an upcoming board meeting about kind of our next steps and processes with the syphilis. Our Commando campaign, we've had roughly 470,000 impressions on dating apps. So some of the other indicators for this program are outreach testing. We've done almost 500 tests with about an 8% positive. 163,000 condoms in 2023. And chlamydia is the highest rate in the past 10 years. I feel like a lot of these things are the same things you guys saw last year because they are continuing to increase. We have had about 85 syphilis cases, and that's just the infectious one. So that's just primary and secondary. That does not include the latent stages, which is almost double our 2020 cases. Primary syphilis rates in women have increased more than 100% since 2021. And congenital syphilis, a 400% increase in cases since 2019. So like I said, these are all the same similar stats that I reported last year, but we just increased in the year as well. With our WIC program, it is celebrating 50 years this year. In total for Douglas and Sarpy County participants, we had 22,525. Our Midtown office had 5,600 participants, and our 120th had 4,800 participants. We do our PHQ-4 questionnaire with about 1,100 respondents, and 5.7% of those were referred to mental health services. In 2023 fiscal year, 27 children referred to the lead poisoning prevention program, and 235 children were referred to the early development network. So that just shows that we're really working to integrate all of our programs within the department within one another so that we can have a good referral system. Some of the other accomplishments and challenges. So the waivers ended in 2023, so we fully opened all of our clinics, which is exciting. We're seeing people in person again, but the downside is our participation has been dropping. And Charles Drew has opened up a new office. We did lose the Wick Farmers Market, but have also partnered with Whispering Roots and Big Garden to offer a different version to give some of those similar benefits. We have 3 new breastfeeding peer counselors, and then staffing has been kind of an ongoing issue with our One World and Charles Drew offices as well. And then Midtown office space, we are battling for making sure that we've had some issues with the actual space over there. So it had been without power for a while and some heat issues. So we've been really working to try and figure out how we can get that space how we would like it. Our health promotion program. So we have our community health workers. New Lens is a program that was really created by one of our community health workers, and you will hear more about that following this presentation. We're excited to have Jordan present on it. Our diabetes prevention program, so we've had 3 additional community health workers trained in diabetes prevention, and we are working to try and find a new recognition site. One World was one, but I think now we're looking for an additional one so that we can partner up with them and provide folks to be trained. The colorectal cancer screening program has been a partnership with UNMC, and we still have navigation still happening. We've got funds for food and housing. And then also, as I mentioned earlier, the health department integration, really making sure that our community health workers are getting to know each of the programs within our department and can be embedded and be that referral source throughout each division, each program, so that we're really breaking down the silos in our department. Femur Baby Blossoms. We've had 2 staff who were working on this project and they left. The public health nurse position has been posted and reposted for about almost, I want to say, almost a year now. And we're interviewing again next week. We've offered it to other folks, and just this position is very hard to fill. The salary wage for public health nurses, and yeah. So we're hopeful that we will find someone here in the next couple weeks that will work out for us. We are working on an updated plan for Baby Blossoms, doing some staff restructuring, and the next meeting will be happening here hopefully in the next couple months, next month or 2, I think. Continuing with health promotion, we have our overdose prevention program. So we did receive funding, and we finally got our budget approved through CDC, which, as I mentioned, that funding is about $890,000 a year for 5 years for our Overdose Data to Action local grant. Legislation was passed this past year, and the OFR team will start to review cases soon. So some of the issues with that it'll be logistics. So the first case review will obviously have some quirks to it that we will need to work through and figure out what's the best process for our group here in Douglas County. We've had new staff brought on to assist with our overdose prevention program and new partners and contracts, so we are excited to be moving forward in this space. In our tobacco program, we have updated the Clean Indoor Air Act complaint process. We've also been working with MOTAC on the smoke-free housing website, and then also working with mental health providers about tobacco cessation. So some of the major goals, we are always looking for funding. With STI Outreach and Clinic, we did have some cuts in funding. However, we are working on some applications here to Sherwood Foundation to see if we can help supplement our clinic and surveillance portion. Overdose prevention we received, so that's exciting. And then with food insecurity assessment, that would be our nutrition environmental measures survey. We are hoping, I've received a contract from Creighton about REACH, and we're just finalizing some items in the contract, but hopefully that will be able to help supplement and help us get that assessment done here in Douglas County, and also partnering with Sarpy-Cass and Pottawatomie County on that as well. Our infant health work, we are just hoping that we can get some folks hired because we would love to move forward in this space. It involves infant mortality rates, congenital syphilis, nutrition, breastfeeding, all of these things kind of come together, and I was really hoping to have some more impact in that space, but when we've been down staff and trying to hire, it's made it a little bit difficult. Collaboration between programs, that's been the one big thing, is getting our community health workers and having all of our programs know about one another and be able to be that referral source and really promote each other as we're out in the community spaces. Last year, I had put that one of our big goals was to be a health literacy champion, and I'm happy to say that we are. We have received the electronic badge that you can put up on your website that we are now a health literacy champion. And we're finalizing a social determinants of health screener that we'll also use as a referral for our community health program. And so I know I sped through that, but I just wanted to give you guys a quick overview of kind of where we've been at and what we've done over the last year. So, any questions? Sure.
What's your barrier with the public health nurse? Is it the civil service pay scale?
It would be pay scale as well as finding someone that's interested in doing this work. The fetal infant mortality review is a very specialized position just because we're looking for folks that don't want to actually be doing one-on-one patient care, but also has that nurse background. That's why we're really insisting on having a nurse for this position, but also knows public health, knows some of the other issues occurring, can work in a room and really pull partners together and lead that room in a case review. So there's some nuances to the position for this one as to why it's a little bit more difficult, I believe, to find someone for it.
I forgot the term. Have you reevaluated the position with civil service? Because you sounded like there's some other management leadership stuff up under there that may justify the scales change.
Do you remember when it was?
We have gone through it's in a job audit right now.
Okay.
So
I will be thrilled if we can bump it up, because I mean, for the amount of kind of intensive work that this takes and the pay scale that it's offered at, it really is challenging to find somebody who wants to be paid that rate for that kind of work. And so if it does come back from its audit, reclassified, I know it'll be tough on budget, but I'll be thrilled.
And our public health nurse is also the same job description for our TB nurses, our STI and immunization clinic nurses. So it's all encompassing, which is a little overwhelming when you look at the job description. And we've talked about, it used to be split. I'm looking at Justin because he was around when there was a split in it, and then when they did get combined. So
yeah, we used to have more tiers. So you'd have a public health nurse 1, a public health nurse 2, kind of similar to how our environmental health is still set up with a 1 and a 2. I think there might have even been a 3 at one time. And I don't have the history about why everything was combined, other than trying to kind of flatten things out a little bit. But that does become a challenge as well, because basically, somebody who's doing clinical work is potentially at the same pay scale as somebody who's doing what I would consider more maybe higher level work, where they're having to pull people, they're facilitating groups, they're doing those those case reviews where you're not just looking at clinical components, you're looking at social components as well. So it's quite a bit more complex, I would say. So we'll see how it comes back from.
Okay. Well, no, just let me
HR.
know what it says, so
Yeah.
I know. Okay. Because you said a year.
But
Okay.
even before that, when it was open after Carol Isaac left, it was open for about a year until we found someone. So
Oh, wow. Okay.
it's just a hard position to fill.
Okay. Let me ask you.
Yeah.
I was surprised. Why does I'm just surprised if Offutt needing WIC. I'm gonna ask you this question now because in your report you all about to sign a WIC contract with Offutt.
So
I mean, why would the
Offutt,
Air Force be
it's not, it's an MOU. So it's just, and I probably don't have all the information, but they've got some services, I think, there for breastfeeding and nutrition for their folks on base.
No, I was just curious. Why would somebody in the military not have that resource there with them?
Well, I think of it as WIC offers a multitude of different things. So I think this is just a support system for nutrition and breastfeeding. Oops. And that version of it, but I could be wrong. So I'll do some digging and find out a little bit more for you.
Well, yeah, I'm just curious because it's when you see us, I'm thinking WIC and the military, and I'm like, so why, is it? I mean, the military has its struggles with gender things at times. I'm wondering if that's a remnant of that. But when I read that and you all had a contract with WIC, I'm like, why wouldn't the federal government be providing support with that in general and have to go outside of that? I was just curious about that. If you ain't got an answer, I'll wait to hear. But I was just curious about that.
Yeah, I can find out a little bit more.
Okay, all right. I guess lastly, the hotline's still under you?
Jamin.
Oh, okay. Then I'll wait. Okay.
Thanks for the updates.
Yeah.
Curious about the position for the femur nurse as well. Has there been thought about maybe adding a component to like a shared responsibility with social worker or behavioral health support? It just seems like the intensity and like burden of that job is probably a lot for one person, no matter if they get a pay increase. So just wondering if maybe that's a consideration.
You mean like having two positions work on
Yes.
this? We haven't gone through having two folks kind of work on it, but that's definitely something to consider. I know our biggest thing has been with the state that working with DHHS and having our contract with them solely be focused on having a nurse do this work just because of the intense case review piece of it. But I will definitely start looking into it. There's also, I hate to say these things, but budget issues as well with hiring another person to have a dual component into this. But I will definitely look into it.
I just think with the urgency of the matter, it's kind of, it's been a priority for all of our health systems thus far. And it just seems like with the outcomes now, we really need to do something. And this is holding up progress, it feels.
Yeah, I wish I had better news. And it's just tough when we don't have anyone to do the work. And we can only do so much.
Sure.
So
I definitely
we've been
understand.
trying.
You
We've
guys
been
have
putting
been
it out to as many different places. We've offered the position to a couple folks, and it's been turned down. So we're trying.
Okay. And then you mentioned something about the diabetes prevention program and looking for a new recognition site. What does that entail, or can you tell me a little bit more about the diabetes prevention programs that you're running currently?
Yes, I might actually have Patty come up and give a little bit detail on the recognition piece on the recognition site because she knows more about it than I do. So.
So we were using One World as our recognition for the CDC, and it's very time intensive to do all the paperwork for that, so we were wanting to partner with another agency.
Talking about like providing the actual classes and services?
We can provide the classes, it's just when you sign up and do the training through the CDC, You have all of the extra paperwork to become a certified agency. And that's where I was hoping that we could just partner with someone who is also doing the diabetes prevention classes.
Okay.
And then we wouldn't have to be, it wouldn't, just trying to work as a partnership instead of having to do everything and do all the paperwork.
Sounds good. And the current programs you have going, or where are they located?
We have, currently we are working with with the Burmese population currently for our diabetes prevention program.
And I believe that's One World is where they're the recognition site currently.
Yes. But their funding is going away, so they have been told that they are not going to be doing the diabetes prevention program anymore.
I'm like feeling a common theme here. We have all these prevention
Yes.
things that are not getting
So
funded.
if you would be interested in helping someone set up a recognition site,
Yes, we would.
please let us know.
Okay. We would definitely be interested.
Is that tied to the federal hit through the budget negotiation? Is
What was
that
it?
funding site, loss of funding, is that tied federally?
With One World?
They were receiving a grant. I'm not sure who that
No,
grant
okay,
was through.
all right.
All right. Well, I'm going to have Jordan come up.
Yep.
So we're excited. Jordan is one of our community health workers, and he has really started this New Lens program from the ground up. It was really his idea, and he ran with it. So we're excited to be able to present on this. All right, Jordan.
Thank you very much. Hello, everyone. My name is Jordan Sedilio. I'm a community health worker with the Douglas County Health Department. I work under Patty Falcone. Hopefully, you guys have been enjoying the weather. I don't know. I see one Creighton Blue Jays fan. If we have any others. Okay, yeah. We made history last night, beating UConn, the first time they've ever beat a #1 ranked team. So that was a cool experience. Yeah. But Matt talked here.
Let me ask you, I'm just trying to get your bearings.
Yeah.
So last time we saw community health workers, there was a north, south, central, there was one working. Where do you fall in, or you
So-
an added person?
No, I've been here for about 2.5 years, I think, coming up. And I think at the time, had been a year ago, I want to say.
Yeah, I mean, because when we saw them across the street, you weren't there, so I'm just trying to figure out where you fit in the.
Gotcha.
Okay.
What? Yeah, I was
You
actually there. So I handled the COVID test kit
okay.
distribution at the time.
Then my memory is bad with that.
Yeah,
Okay,
no,
never
hopefully
mind.
make a little impact today. But no. So we had someone at the time, I think, working with the refugee community, and she moved on to a different position. And so I kind of took over that. Unfortunately, I don't speak any other languages, but the people working at the Heartland Integration Center have been a great help, and I kind of took over that role and filling in at HIC. So yeah, no worries. But I'm not here to talk about sports or any of that. I'm here to talk about Project New Lens. And if you have any questions at the end, just feel free to answer. Do I just use this? Perfect. So I'm going to be kind of talking about why is mental health important. I'm sure all of you kind of understand that mental health is important. And then I'll talk about what is Project New Lens, the activities, ultimately the results, and the conclusion. If you have any questions, feel free to ask. So why it's important, and I found this data online. I'm not sure if any of you have seen it, but Nebraska was currently ranked as the top state for mental health support. And that was through a company called Soliant Health, which offers healthcare jobs, staffing services nationwide. But they released that Nebraska ranked as the current #1 state. And this was on CNBC, and this is a direct quote. Nebraska claimed the #1 spot largely because, compared to other states, it has the lowest level of youth between the ages of 16 and 24 who aren't working or in school. And there's a lot of other factors that play into that part. But it was a really good survey that showed we're doing what we can as a state to provide mental health support to our community. And this helps empower and educate our youth, and I think that's the smartest thing. People are going to continue to live in this community and continue to thrive and make it better. We're empowering and helping them. But what is Project New Lens? And we'll talk about that right here. So Project New Lens, the reason I'm here to talk to you all today, it's a youth mental health project that provides non-traditional ways of mental health support to the youth of the community. I can't speak for everyone, but I know when I think of mental health support and therapy, it tends to be like a one-stop shop, right? You sit in a room and talk with someone. And when we interviewed the kids, which I'll talk about in a little bit, the idea they had behind mental health support and therapy when we asked them questions, sitting in a room and crying. That was at least 7 out of the 11 responses, was sitting in a room talking with someone, crying and showing emotion. And so the idea behind that, especially in North Omaha, where these kids came from, we kind of wanted to destigmatize that. We wanted to show there are more ways than just sitting in a room and talking with someone. And the youth, so this was an 8-week-long program that took 6 boys from North Star and 5 from Girls Inc., and they did different activities. This included equine therapy, which is animal-assisted therapy. I'm not sure if anybody has heard of that, but it's a great thing. Expressive art therapy and ecotherapy, and I'll talk a little later on kind of what they did during those activities. But the goal was to destigmatize mental health and show different forms of mental health support that they can take into their everyday lives. And so the activities that they went on were what I said: equine therapy, ecotherapy, and expressive art therapy. And I'll just list some things they did at these sessions. I'll start with equine therapy. We partnered with Scatterjoy Acres. I don't know if anybody's heard of them, but they're a pretty prominent animal-assisted therapy. They used to be out in North Omaha, but they actually moved their location to Murray, Nebraska, which that's where we did the location. And it's actually great for the kids to be able to get outside of Omaha. So we had 6 from North Star and then 5 from Girls Inc. And these are 2 prominent organization after-school program and suburb programs in North Omaha. And so we did equine therapy, and during the session, they did existential metaphor-based challenges, tasks, and skills. So when I observed this, they found new ways to handle problems. For instance, they had a hula hoop, and then each of them had their own kind of pony horse. And the idea was to get the horse through the hula hoop. So they worked with the licensed therapist on how can they get through this hula hoop. And the kids at first, they tried to get them just to walk through, and the horses didn't want to do it. So brainstorming, working on group effort, social skills, things like that. They found different ways to solve a problem. They spent the last part of the class kind of debriefing on what they learned, and equine therapy tended to get the best responses in terms of being one with nature, and or being one with animals. It might sound a little cringy or cliche, right? But it really was being one and seeing how can I be with an animal in my everyday life? How can I appreciate something as small as a dog in my life and use that as a mental health supporter, right? But the next one was expressive art therapy. And for that was probably the most mindful activity. They sat in a room. We worked with the Next Foundation, which is stationed in the Millwork Commons. I forget what that building next to it is called. I think it's the living room, or Mastercraft, something like that. But basically, so they did a centering and mindfulness process. And my experience I worked before this job as a behavioral specialist and a teacher at an alternative school. And every day they did group therapy and social skills. And when they went into class, they did mindfulness meditation for the first 5 minutes of class. That's where I really saw how impactful meditation is. And that's how impactful it was in this program as well. They sat in a room and just meditated with each other. And when we interviewed the kids post-program, that got some of the highest reviews, just sitting in a room and meditating. And for kids 14 to 17, I was like, you guys can just sit in a room and kind of meditate alone. That's crazy that you guys love that. I was really surprised by that. But then they spent time making solo art. And then after that, they described what they made. What was in their brain when they made this? What was going through their thoughts? What, I guess, impacted this picture on the paper? And then they shared with the group, and that was that. And then for ecotherapy, which we actually had the most sessions of, that was ran by Megan Smith-Salins and Melissa Brazil, Wild Tree Collaborative, 2 private organizations, private practices, who are licensed ecotherapists. And ecotherapy is therapy through nature. So in the picture, you can see one of them. We went to Fontenelle Forest in Bellevue, and then we went to Luritz Garden. And for this, they did a lot of different things. I won't list everything, but meditation and grounding activity, forest activity, finding yourself in the forest, a compass creation, group activity builds off finding yourself, awakening your senses. So using all your senses to kind of absorb what's going on around you. Those were just some of the things. And I don't know about you, but I know after I get off a long day at work, being stressed, just being able to go get a breath of fresh air, there's a reason for that, right? Absorbing what's around me. And I've been doing a lot of hiking with the weather we've been getting. And the kids appreciated it too, being able to just take in what's around them. How can they take this into their everyday life? And I have right here a direct quote from Project Elevate, which is a youth research group that worked on providing data and research for this project. They said, regarding Goal 3, the facilitator wrote that they heard youth discussing that they were reminded of the mindfulness skills that they learned when they encountered nature in their neighborhood or backyard. The second facilitator said that the several participants expressed interest in continuing to engage with the natural wild world to reduce stress, feel connected, and calm themselves. So here, just some of the results that we had. The kids seemed engaged. They seemed excited. They had ample time for reflection. The information was presented in a way that is understood by youth. The concepts are defined when appropriate, and the participants can ask questions to clarify, express opinions. The next thing, this chart that I was just talking about, table 6, when asked the therapist, do you think the kids found new ways to implement mental health support? Both the therapists agreed, yes, absolutely, they found new ways. The activities were facilitated effectively. They included inclusive language, and they seemed excited about the content. So ultimately, the conclusion, DCHD's larger goal for the program participants were to decrease stigma surrounding mental health support and increase methods to support their mental health. The curriculum developers, which were Project Elevate, the youth research group, were interviewed at the start about their hopes for the program. Some of the hopes included participants gaining an awareness of the larger context in which they exist, finding a personal connection to nature, and feeling cared for, respected, and listened to. The ultimate observation and result of this project, through surveys, observations, and analysis of collected data, program evaluator found the program was successful at decreasing stigma surrounding mental health, encouraging connection with peers so they felt cared for and listened to, and inspiring a deeper connection with the broader context in which they live. Future implementation shows that we need to add more sessions and longer sessions. And that was the biggest kind of coincidence or what each kid said. They wanted more sessions and longer sessions. When asked about how they felt about the program, so we interviewed the kids before and after each session, and then we interviewed the kids before and after the program in itself. And after the program, when asked about how they felt, they said, I was more peaceful. It was good for the soul. It taught me life lessons. It was amazing. When asked if they felt like they gained anything from the project, it helped me work together as a team. It brought me a lot of social skills. When asked, would you recommend this to someone? They should join. It was really fun and would help me unlock new potential with your mental health. And then when asked, what did you think at the start and what did you think at the end? I didn't want to do it at first, but once I got into it, I didn't just like it, I loved it. So that's kind of what Project New Lens is. Do you guys have any questions about the program in itself? If not, perfect. Thank you for giving me the opportunity to speak.
Yeah, let me start off the bottom. I'm just curious. What are the comment of inclusive language?
Yeah.
How are they going to tweak that?
I'm sorry, what was that?
The comment on inclusive language, I'm just curious, I'm assuming they're evaluating it.
Yeah.
How are they going to go about, I'm just curious how they're going to.
So when I
reverse engineer it and get at that.
So how did they, how is that defined using inclusive language?
Not so much as defined. I guess obviously somebody had an issue with it. That seems to be like the
sure.
only negative marks about the program.
Yeah. So when it says a little bit true, is that what you're kind of referring to? I talked with this with Project Elevate right when I came out because obviously we want to use inclusive language at all times. In the specific incident, and we kind of, whether it's disagreed or not, there was an activity in which the kids did a taste testing, and there was jam, and that was part of the what I said earlier with awakening your senses. So they went to Fontenelle Forest, engaged in multiple activities, hearing, sound, smell, and tasting was one of them with jam. And 2 of the girls didn't want to do it. They weren't into the whole eating jam situation, so they didn't. So it wasn't about inclusive language, but it was more rather the activity itself, and they didn't have kind of a backup plan.
Okay.
The ecotherapist at the time, so I don't know how that falls into the inclusive language part, but that's what Elevate said when I asked them, followed up with him about it.
Okay.
Yeah.
So I'm just curious, what's the next phase?
Next step of this?
To
Yeah,
get it,
yeah.
To get it to scale.
Am I able to talk? I don't know how much, I don't want to get ahead of myself or anything. I'll just go right into it. So yeah. So this really last session focused on psychotherapy in itself, approaching as a therapeutic, and now we want to say psychoeducation, showing them different forms of not just a therapy license, but mental health supporters. So we have researched a bunch of different forms of mental health support data research, and we came up with things like fishing. So we're planning on launching this program again, but launching it and extending it just like the kids wanted. So there's going to be fishing, cooking. We're kind of finding the organization right now, boxing, art again, equine, eco, partnering with Rabble Mills to work on music and another physical activity, because as we all know, physical activity is a great mental health supporter. So yeah, we're hoping to launch this again in the summer, working with Boys and Girls Club right now to provide the youth and extending on this with different ideas.
So 6 were from girl. I mean, your size 6 were from Girls Inc. 8 were from West.
So it was 6 from North Star and 5 from Girls Inc. Yeah, Girls Inc. we wanted to do 6 and 6 for the pilot of this program, but Girls Inc. had a lot of internal issues going on at the time. So like last second, there was someone new in charge and had to get connected with them and things of that nature. So we were only able to get 5 girls at the time from Girls Inc.
So I'm just curious, are you still at Girls Inc.? So did they have to connect with you to do this? I'm just curious.
Yeah, I don't say I never got the chance to connect with you.
Yeah, I'm on the clinic side.
Oh, okay, there we go. Yeah. Yep.
Okay. Anybody else?
Oh, here we go.
So you mentioned like the potential for cooking as part of therapy down the
Yeah.
road. I think No More Empty Pots does some stuff with that, or at least they
Yeah.
used to,
So
that might
I
be
actually met with them a couple
resource.
times. We're looking into that right now, and No More Empty Pots, especially. So we're implementing it not only in North Omaha this time, but we're doing it in South Omaha as well to be able to extend to more community. And we're making sure to use organizations that are based in those locations. So we want to be able to use the South Omaha. We don't want to use No More Empty Pots just because that's more of a North Omaha location, right?
Yeah.
But for the North Omaha, yeah, we've been talks with them to partner with them on this project and get them involved. Yeah.
So as you go into your next phase, how many youth would you be looking to expand to?
Great question.
Keep it the same size group or?
Sure. For the pilot, working with ecotherapists especially, it was hard because we wanted to get the right number. We don't want to overwhelm the kids or the therapists. But for this session around, we've been talking with a lot of these organizations, the Next Foundation, things of that nature with art therapy, and saying how many kids can we do? How many kids can we have in one session? And it is looking like we're going to be able to add more. I don't want to give a firm. I'm hoping for at minimum 8, at maximum 12, having 12 in one session. So ultimately, we're hoping for 24 kids, 12 from North Star, or 12 from North Omaha and 12 from South Omaha. But we're hoping to increase that number by a few if we can. It's just about working the budget out and things of that nature. Yeah. Any other questions?
First, I just want to congratulations. This is amazing work that you're doing.
Thank you.
In our cultures, in our different minority groups, mental health is really a stigma that we don't talk about within our family groups.
Yes.
Just presenting this information to the kids in a different lens to be able to say it's not crying in a room in front of a stranger. It's more than that. That's just amazing work. I think this is the best work that I've seen and the best approach that I've seen when we sit in different rooms and talk about mental work in our communities of color. So thank you for bringing this up.
Thank you.
Question, who are your partners in South Omaha, and is there a cost for the kids participating in this program?
Good question. So when you say partners in South Omaha, are you saying the ones who are bringing the youth to this activity? It's going to be Boys and Girls Club. We're already in talks with them. They went to their board and everything should be approved as far as I know. So yeah, and they'll be handling, and then like I said, we're going to be working with South Omaha organizations specifically. So for boxing, while I'm going to try and go to B&B for North Omaha, someone else is taking the lead for the South Omaha, and she's not able to be here today. She's sick. But she's working with Victory Boxing, which is a South Omaha prominent boxing organization. Yep. And then, sorry, what was that second part of that
Is
question?
there a cost?
Cost? Nope,
for the
completely free.
kids
Yeah,
to
we made sure to be able to be as free as possible, and then especially going to those organizations. Sometimes they're out all day. I know for Scattered Joys, it's a 40-minute drive out there, 40-minute drive back, 3.5, 4-hour session. So we made sure to feed the kids as well, but it's completely free for the kids. We just had a meeting with the parents the first time around, be able to talk to them. I know as a father, I'd be a little uncomfortable handing my kids off, especially you hear the words therapy, mental health support, handing my kids off. So we made sure to give the parents the chance to get clarified on what their kids will be doing, talking with these organizations and things of that nature.
Amazing work. Thank you.
Thank you very much. Oh, thank you. All right, awesome. Well, thank you for your time today. It was
Appreciate it.
nice talking to you.
Appreciate it. We'll go on to department reports. Any questions from anyone for the department reports? Okay, let me note, just as a point here, so I think I asked Dr. Hughes if she had anything legislatively, so I want to put it on everybody's consciousness. I think I mentioned in January, one of the issues, or either in December, was the inheritance tax and where it plays with county revenue. So for those that may not know it, inheritance tax is I wouldn't say it as a wealthy tax. The reason that it's getting kind of targeted is because it's kind of it hits farmers sometimes on what they pass down, but it's a tax that affects probably 1% of Nebraskans, but it's a real issue with farmers. So now it's got a target on its back. It never had a lot of traction. It got a hit last year and got reduced. This year, it was on the floor yesterday, and somehow it probably is going to be today, and it got pulled. So something must be going on. So they must, I don't think it's out the woods, but the fact is it's about an average budget line, about 12 to 17 million for the county. The tie here is when there's a shortfall in budgets and balances need to be made, that is kind of taxed that's used as another reserve. And so part of the health department's budget comes from that. And so we just need to be on guard for it. Particularly the letter for the budget has not come out yet. But I am saying that because when I noticed in that report the fee raise, I'm thinking you all might need to take a look at that, because if this happens, it's gonna be a kind of all hands on deck. So if, like, you looked at this fee and it hadn't been raised at a period of time, we probably should do a good scan of the fees and see what may be eligible to make up that balance if something hits. And I'm not saying this is a definite, but I'm saying this is having a pocket, because one of the big pieces in the debate was if the inheritance tax is gone. I mean, you got the inheritance tax that's directly us, but you got the local lid piece that affects everybody, and I don't think both of them can go through. If the inheritance tax was to go, I need you all to plan for that discussion we always have about exercising the lid, because the window may come, because if that inheritance tax hits, there's going to be some hard decisions, and I don't know, a lot of locals or a lot of counties probably going to do some lid adjustments if they take that away. So I need you all to have that ready for discussion and ready to go and think through that. So I just want to put that on the record for you.
Yeah, go ahead. I was just going to say we've already been having those discussions internally about kind of contingency plans, but since that's Justin's wheelhouse now, I'll let him speak to it.
Ish. It's our wheelhouse. But we have started looking at our fees, and also we do a lot of work for free. So if we're looking at nonprofits and things for food inspections and things, we've started looking into charging those nonprofits, which is probably a conversation we need to have, because that will include schools. So right now we do all our schools for free. And it's a significant amount of work and also a significant amount of revenue for the health department that we're not tapping into to support those programs. So we've started some of those discussions. We've talked about giving a year notice so that schools and other nonprofits can prepare for that, and we don't drop a heavy weight on them without some sort of a notice so that they can plan.
And I'll add to that we do have meetings set up to have conversations with community partners
Okay.
about these things. So
Okay.
hopefully we will have them well prepared before that
Does
happens.
that include, sorry, the daycares too? Because
Yes.
Yeah.
you're going to charge daycares?
If they're inspected,
For
yeah. So
inspections, yeah.
Because what's the size?
the problem that we're running into right now is the department is supplementing that that cost, if you will, to provide those services to nonprofit organizations in the community. I think we're the only health department that does inspections that does not charge. Lincoln Lancaster does. I think they have it's a reduced rate perhaps for nonprofits. So we're looking into that.
Because I know we looked at this before, and our sticking point, I think it was like 5 years ago, was the small in-home daycares and that kind of thing. Like, is that enough burden where we're going to cause another daycare thing? So that just
No,
I don't know. That's
I hear
something
you.
we need to talk
That
about.
was talked about, but I don't want to dramatize it, but I definitely don't want everybody to understand if this inheritance tax piece goes away and the other stuff that's there, this is a serious financial issue that the county's gonna be in. So it will be everything on deck.
Yeah, and Dr. McNally, I would also add that as we're talking about that, we are looking at fee structures. So it's not just a flat, everybody gets charged the same thing necessarily. In my ideal world, and I realize my ideal world is not everybody else's ideal world, but I would prefer to see something like a sliding scale or something where you're paying commensurate with the size of your organization. So, like I said, we're just starting conversations with the community about this, so certainly I don't want to panic anyone and have anyone think that this is happening tomorrow, but the conversations are certainly happening, and we're thinking, Justin has been in my office for many hours as we have talked about what happens if this is reduced or goes away, and we need to figure out how to keep serving our community in the way that they need us to.
No, that's good because we're on the same thought pattern. My thought was you need to start prepping people's minds that this gonna be something if it happens.
Yeah.
Okay.
Well, and looking at the diversity of funding as well, and not just relying on one pot of money or two pots of money, really looking at how we can better diversify going forward so that we can have better sustainability over time and not, our services aren't waxing and waning so much with taxes, essentially.
Yep.
Yeah.
Okay. Nothing else? Is there no, for the record, there is a meeting scheduled next month, the meeting date. Unless I hear from anybody else, I didn't hear anything alarming today that justifies the March 1st meeting. But if something happens, you need to let me know within the next week. If not, we'll plan to cancel that. Is there a motion to adjourn?
Motion to adjourn.
Motion by Festus, is there a second?
Second?
Roll call.
Yes.
Yes. Alrighty, see you all, thank you.